So good afternoon. I'm Glenn Galton, Director of the Center for Global Health. And on behalf of Penn Medicine and the Graduate School of Education, it's my pleasure to welcome you to the Center's annual Distinguished Lecture. But of course, I'm especially pleased to welcome and introduce our featured speaker, Dr. Agnes Binagwaho. As outlined in today's brochure, Dr. Agnes has many, we could have filled more than the brochure, many career accomplishments and has received numerous awards appropriately for these. But most notable to me are her role as the former Permanent Secretary and then the Minister of Health for Rwanda, and her faculty appointment at Harvard and the linked association and affiliation with Partners in Health, all of which have contributed directly to her role in guiding the development of the Rwandan healthcare system. But more than any role or reward, it's what Dr. Agnes stands for, if not demands from us, that shines the brightest. Trained as a pediatrician and having practiced firsthand on the front lines of healthcare through both disastrous and in more calming times, it is her beliefs, her moral standards, her fantastic organizational and motivational skills, her belief in science and evidence, and yes, her persistence, you'll hear about that in a minute, in an expectation that we respect each other and every human life, and that is what we admire so dearly about her. Simply put, she is a global champion of human rights, of awareness and access to health care, and of the right of all people to expect positive outcomes from their care, but most especially for the poor, the underserved, the dispossessed, and the disenfranchised. Most recently, Dr. Agnes has been appointed as the founding Vice Chancellor of the University for Global Health Equity in Rwanda, thus extending her lifelong mission. And she will speak today with us about that mission, Rwanda's journey to create an equitable health system. Dr. Agnes.
Do I have something to say after all this? So, thank you for having me. And thank you for sharing a moment with me. I'm going to, first of all, I thank you, Glenn, for organizing this. I came here knowing that I had two friends in Penn. In fact, I have already rediscovered 10. I have here you, so many people. And even those I don't know, we are moved by the same fire, the same spirit. We need a better world, isn't it? For the poor, for the vulnerable. So I'm going to bring you in a journey of the impossible, a journey of hope, and a journey that shows us that if we have made it in my country, there is no country where it cannot happen. There is no place on earth where the poor, the vulnerable, cannot be cared of. There is no idea that can stop us to do it. So, why? Because Rwanda, you know where it is. I hope you have done your homework before now. But what is important to know is that still today, we don't have a GDP that reaches $800 a year per person. So we are poor. However, 23 years ago, we were destroyed, and that's why people say, they will never make it. Everything has collapsed, really collapsing. Social capital, 1 million deaths in 100 days. We are celebrating now the commemoration of the genocide. And I'm here happy to pay tribute to all the victims and the survivors. And 2 million refugees out of 10 million people, 1 million people killed. All infrastructure destroyed. When I say destroyed, it's really destroyed. And that's what we were. We were already in bad shape, but there we were really. People say they will never come out of it. But we decided differently. We say, are we going to do business as usual as we do in the world, or are we going to do something different? And we left ideology, guessing, magic out, and we decided to do something else. We decided to go through capacity building, educated people, because if there was some people who have direct the genocide, the majority of people who killed, they were used because they were not educated. We decided to go for scientific evidence in health and everything. And also, we set and say we need to innovate. No country have come out of this quickly. What we risk is the cycle of destruction starting. We had the power today, we revenge, and in 20 years, the cycle will turn. And so we needed innovation. We needed to draw from what we know of the world. It was already global there. What lesson can we take from Serbia? What lesson can we take from Albania, from other countries where they have same disasters and when they have to rebuild their society? And my task was to rebuild the health sector. So we decided to do differently. We understood that the problem is leadership. We decided to create a leadership at all levels. Leadership starts in the house, guys, not in the kitchen, in the bedrooms. After in your village, your community. The top is okay, but if you don't foster the leadership at all levels, you don't make it. We also say we don't have institution. We need to create institution so that when the people who have goodwill now and the knowledge now leave their seats for somebody else, they have something to work with that correspond to the good the people need. And we decided to serve the people where they are and to collaborate. By the way, I'm here to start collaborating with you. But at that time, we decided to collaborate inside the country. There was not so much collaboration, but also outside the country. What can we do better with what we have? So, first thing, bring back the refugees. Because we cannot have part of our people suffering in our border, be frustrated. Look what happened with Israel. Israel is in bad shape because they have poor people who have nothing to lose. So they will not get peace and development because they are depressed, they have no hope, they don't know where to go. This is the health in refugee camp. That is a big part of global health. So we decide to bring them back home and to give them back what they had before going. So if some people like me, my family lose everything in the year 60. But somebody took the land of my parents, isn't it? So we came back, and if we take that land back, people who grow up there, where are they going to go? So you create another frustration. So we decide to give back everything to those people who were in the camp and to guarantee that. They came back, 2 million, and all the babies made in the camp, because in the camp you do nothing. So you have a lot of time, you don't think about family planning. So they went and they came back more than they went. And we had to resettle them and to create health system, to create school, to create things that were not existing and rebuild what we have lost. But we didn't forget also what happened. So we create also a room for commemoration, not forgetting, honor the victim. Nothing can repair it, but at least we have the two. And we decide also to innovate for our future. So we sit and we imagine how can we do what we want to do. And not only the health sector, but all the sectors. But we face resistance. And the biggest resistance, the most shocking for me, was the scientific denial of the right to do what we do. This is Mr. Maurice King would say in 2 articles in The Lancet that due to the pressure of population, we should not treat children like Rwandan children, in his article, with diarrhea, because if they survive, they were promised to a miserable life. Lancet. 2 articles. But we face also political resistance. Remember when we decided that our people had the right to have HIV treatment? They say they have no clock, they have no, etc. And now what we see that our people are more resilient in facing chronic treatment, and that the compliance to treatment in Rwanda and in Zambia, etc., is better than here. So they were right, and I'm so proud to have contributed to make them wrong. And what innovation did we use? I'm going to, 23 years I cannot tell you that in 23 minutes, so I'm going to pass through the most important, mind shift. Even a person like me, and I'm a good person, I had to change a lot to decide to give up my fear about the people who have killed and it's my neighbor, and to let my kids, friends of their kids, go and sleep in their home. I remember that it was not easy. The mindset, general mindset shift. And also a political shift, the way we govern. Start to say that everybody has the right to health, whatever crime he has done. So we had to give access. And this is not an academical idea. When we don't have enough treatment for all, and when we decide to give the same chance to a prisoner of genocide to get access to treatment, when you don't have enough treatment for the survivor, as a political decision to foster reconciliation. If you are a Catholic, a Muslim, a Protestant, an Anglican, you better go and pray hours to swallow that idea. But we did it. Hopefully, with a lot of mobilization, we get enough treatment for all. But those are hard decisions that we had at each corner of our days. And we also, universal coverage is everybody, but most of all the most vulnerable that doesn't even know they have the right to. And also create and foster a leadership that is accountable, meaning no second reality or false truths or whatever, accountable. And how to make each and every Rwandan accountable. You know, the dynamic of power in a population that is used to be abused or to see other abused. And if they stand up for the right of those people, they are abused too. So how to recreate the empowerment of each and every citizen? It was not easy. Not easy at all. So how we did, we decided to govern in another way. I talk about the partnership. We have 3 clusters. We have the social cluster, the economic cluster, and the governance cluster. The social cluster is chaired by the Ministry of Health and co-chaired by the Minister of Education. But as you can see, you have all the ministries that are important for the social welfare of the population. We have local government, sport and youth, gender, and infrastructure, but you have also what is not here, agriculture, and ICT, and we meet every month and we discuss together the policy, the change in policy one of us want to do. So that I'm sure that health of my people are preserved. Minister of Gender are sure that gender is taken in account. The youth is sure that we don't forget the youth. And employment, that it fits in the policy of employment. Or we decide all together to help employment sector to fit in the policy we need. It has made us fly. It has decreased the administration between all those sectors and make us collaborate more. And when one of us needs to go to the Minister of Finance or to the governance structure, we go as a cluster. No one among us is allowed to bring a policy to the ministry, the Prime Minister, without the consensus of all the others. So when we go to the Prime Minister, it's already a done deal. And we are obliged to. And if we absolutely disagree, we have the right to go up, but it never happened. And also, it allows us to put our resources at the service of another sector to help our sectors to go faster. So we also put everything we did in the development, the economic development of our country, meaning the health, there is no little sector. The health sector, and it's not personal. It's not because I have a big mouth, a big neck, or whatever. Health was important at the heart of the development of the country. So that's how we have managed to put non-communicable disease in the heart of the development of the country. So that means the Minister of Infrastructure is obliged to fight pollution because it's embedded in the policies. And together in 2000, we came with all the country, decide what we want to be in 2020. And so the people made the leadership accountable of what we have decided and agreed together. Out of that, we have the economic and poverty reduction strategy, and out of that, we have the health sector strategy. Now it's the same for education, the same for etc. Meaning all together, we have the same plan. And this is the 12th sector, and you can see that across sector, gender is there. That's how the woman has more high profile in Rwanda, more than 60% of the women in parliament. Soon the men are standing up and say, hey, think about us. HIV is a cross-cutting issue also, but we have universal access to HIV. Nobody in Rwanda can say, I'm HIV positive and I'm being denied treatment. No foreigner living in Rwanda for 6 months, because we need to be sure of the follow-up, can stand and say, I'm HIV positive, or they refuse me a test, or I don't have access to treatment. Non-communicable disease, we put it there. We still find the money for that. We have a problem. The determinants of health are in the heart of all the policies, not only mine, also the other sectors. And you see the house like you see there. There were so many houses like that in Rwanda. Now you don't find one. If you find one, there is a free toll call saying, I found one here. And we call that Nyakatsi because of the roof. And the program was bye-bye Nyakatsi. In 6 months, all the mayor have the task to find the material, and all the country build the house like you see down. So it has restored dignity to the people. The participation process was in the heart of all this. The innovation number 2 was being holistic. It's already there through the social determinant of health. And now it's certainly to leave nobody out, meaning a special preference and focus on the poor. When the poor are in the program, be sure that those who know how to read and who are not poor can benefit as well. And also, they deserve the best. This is a hospital built with the support of Partner in Health and Bill Clinton and others. Met the people where they are. And this is very important. Make sure that people doesn't walk impossible distance to go and get the care you create. And how we did so, 3 community health workers in each village, 45,000 in total. And 4 villages is a cell. There we will have, and we are now have a home-based practitioner, meaning somebody trained 4 months to care about chronic disease and end of life, to avoid people to come just to die in hospital because family are scared and cannot give, let the members die in dignity at home. In each sector of 16 villages, you have the first health facility run by nurses. In each district, a district hospital, and in province, we start now to build provincial hospital with the first place where you find specialists. In district hospital, the first place you find doctor, and referral hospital where you find specialty. This is the map now in Rwanda. You can see that there are health facilities everywhere. And where you don't see, it's supposed to point, I don't know. On top there, it's because it's the national park, and down is the is the forest. It's a place where we just go to visit monkeys and things like that. So, geographic equity. Community health workers for geographic accessibility to primary care. The second thing is financial accessibility. We have created, and also we just tell ourselves, we want to create an universal health insurance. We call the people and say, how can we do that? They give you ideas that you never have. You don't learn that here. They know the true experts are the people you want to serve. And they give us great ideas. And today, we have more than 90% of Rwandan with a health insurance. A portion of them through the community health insurance, those who are in the informal sector, the agriculture and another. Others, like me, I have a formal employment, there is another insurance, but we have the same services. Because I contribute more to my assurance have to give 5% of its profit to the community health insurance. This has a special focus on children and women. You know that even if the woman is doing the work in the area around the house, cultivating, the men take and go and sell and always pass to the bar to buy a beer. So nobody is allowed to have a health insurance for one person. You have to assure all the family. And this is to protect the woman and the kids. We have also gender budgeting. The minister have to show to Parliament what in the budget of health is there to decrease the difference between the genders. We have passed the law that 13% of the budget in the health sector have to be dedicated to health, that community health insurance, meaning the insurance for the informal sector, etc. Innovation, we can discuss that after. Learning every day, being a learning system. Learning by listening to the need of the people and try to solve the problem with them. And also by using technology. We love technology. We run the health sector with 13 software. There is internet all across the country, so all the reporting is done 10 days at the end of each month. They are in the ministry, aggregated. We can see where there is a problem and go there. There is a SMS alert that has helped us in the preparation to prevent or to respond to Ebola. And we have we know where there is nurses, doctors, where they are, etc. So 13 software help us to run, and we have the electronic medical record also. So those technology have helped us to understand better the health sector and to be proactively improving it before a problem. Of course, we have our data, a lot of data. I think those who know Rwanda will know that we have a lot of data. Now we need to learn to teach each and every one at place of work to use the data for decentralized better decision. But we don't like WHO aggregated data, UNAIDS aggregated data. I had them and I never follow them as minister or even before when they were saying HIV in Rwanda is 11%, and when we did the first DHS, it was 3%. So it was an issue because they say Rwanda have inflated to get more money. That's not true. It's UNAIDS who told us that it was 11.5%. So now we know what we face, and we know if the policy, the strategies, the plan we do are accurate because it pay result, because our only measure of success is if there is an improvement in the life of people. We go near the people, but we assure the quality and task shifting with quality. Nurses are underused. Community health workers are underused. Doctors are misused. And we try to make them more human, the doctors. This is another story. But we improved the life, that's cook stove. How many hypertension we have, heart disease we have, because you see the kids, before the age of 3, they have already smoked so much because mom is cooking. We leverage funding from specific disease to do many things embedded in the health sector. This was a big fight. We never give up, and I'm so happy for that. This is how we have built the health sector. This is a lab created with HIV money, but do everything. We have HRH program with PEPFAR money. In the beginning, they told us, don't dream of that, never. If you don't need the money for HIV, we will bring the money to Gabon. So I remember my dear friend, Eric, and I told him that's what we need now. We can provide the pills and do the surveillance, but we cannot handle the side effect of those pills or the long living with HIV because we don't have specialists. We had 1.5 oncologists for 11 people. We had 3 psychiatrists for a traumatized population. So we have managed to do that, and it has bear fruits. As a result, this is what happened with HIV in the beginning. This is in red, the rate of death and the people on treatment. It speaks volume. Now, people are no longer dying as much due to infectious disease, non-communicable disease, but also having embedded the fight for better health in the economic development, you can see that the two go in parallel. That speaks volume to Minister of Finance. You see that the decline of a premature maturity was massive in all areas. Life expectancy, we are now above what is expected for a country like Rwanda, coming from nowhere. Vaccination, we have the best kids. I'm a pediatrician, so I love to insist. We have the best kids vaccinated on Earth. 93% of girls for 12 vaccines, 93% of boys for 11 antigen. And all this without electricity everywhere, struggling for the cold chain. So that's what we call, how do we do that? That is the science of service delivery that we want to teach in our university. Look, Rwanda, we have invested less than $100 per capita, and the decline of death is far better than other countries that have invested a lot. So I hope that this makes you think about this new science of service delivery. Next. This is comparison of the outcome of HIV treatment between your country and my country. In one side, very little number of infectious specialists, doctors and nurses, lab that are not always functioning well, generic drugs, double result than in the US. Do you want our generic drugs, our lab that are not functioning, and our no specialists? I'm ready to give them to you. But the results are speaking volume. The science of service delivery is the next frontier for better health. The mortality rate drop for children, for mothers, fertility rate drop. 91% of our women are now delivering in health facilities with a nurse. Very proud of that. But the most compelling thing is that the poorest has benefit more than the less poor. The rural area has benefit almost 5 times more. So that means we have achieved our goal of equity. We have built hospitals. We have even 2 boat ambulances on the lake. And if before we were dealing with first killers, malaria, HIV, tuberculosis, pneumonia, diarrhea, now we are dealing with cardiovascular disease, cancer, chronic respiratory disease, diabetes, etc. And we try to apply everything we have learned to do that, but we need more science behind. And just want to tell you that the number of deaths due to NCDs, not the people are dying more, but they die less with infectious disease, so the proportion increase. And there is a lot of study that have shown that it's going to be more, and more. There is other constraints. We know that our struggle now is to continue to do what we do for infectious disease. Don't give up. Need still to work on that very hardly. But if we don't tackle non-communicable disease, we are going to stagnate. However, look what WHO say, why I don't like those calculations. They say that if you treat for a cost of 3 times the GDP, there is no value for money. Okay? Rwanda, I told you, less than 800. So we cannot spend more than 2,400. Look at this. It's me and Margaret Chan. On her head, you can, if we have the same car accident, when you have spent 2,400 on my head, let me die. But for her, you can continue to $250,000. It's still value for money. And if you look, even as a woman, I have more, you have more kilogram per kilo of me than of her. So it's a joke, but this is our obstacle for treatment of non-communicable disease. And HPV vaccine is an example of that. The majority of cases are in Africa. The majority of deaths are in Africa. But introduction, we fight with WHO and CDC to introduce the vaccine. Now they will deny. They will say, no, you didn't understand us. We were always with you. I'd make a deal with Merck. Cannot talk about the deal because there is confidentiality. But they went to Merck and told them, don't trust them, don't give them money, they will spoil your reputation. They don't have a cold chain, they don't have enough, etc. And I had to write a letter to our friends in White House, Niels Delaire, who was head of the Global Fund, say, remove all HPV and replace it with HIV. Same speech, same notion that poor people, we should not fight to find solution. And over a weekend, he never answered me. Over the weekend, WHO came in the meeting and CDC, somebody said that we are against, but no, we are very supportive. And we had the vaccine. By having a vaccine nationally, I told you that 93% of our girls are vaccinated. Gavi trusts the capacity of country to do it. Now Gavi paid from $700, it's now less than $20. Okay? And if we don't take the risk to fight for saving the poor, we'll never have nothing. And so I like this tweet because somebody saying that HIV vaccine encourages girls to have sex is like saying the flu shot encourages people to link elevator button. So this is it's true. But there was an article again in the Lancet saying that it's not cost effective. How can I do that? Selling my girls to a pharmacy? Written by, in Germany by, but somebody from Africa, because I guess that Odreago is somebody from West Africa. How the hell, if you meet him one day, give him a message from me? Because it's scandalous. I found the money. I make a deal for 3 years. And I know that we can, if we succeed, Gavi will be with us, Bill Gates will be with us. And those who are going to say, sustainability, sustainability, we don't care. Even if we don't succeed at the end, at least we have saved a branch of girls. And should first tackling other vaccine, they even did study that we had 93% all vaccine, the coverage for all other vaccine. So this is what they say. We have serious doubt that this arrangement is the best interest of the people. Who are the people? Do you feel that arrogance that is against the work we do every day? And you can read what they have wrote, but it's disgusting. So of course we write back. And when the possibility of prevention exists, return of women to die of cancer solely because of where they are born is a violation of human rights. And this is the global fight we need to do all together. So we did it. And first shot, first success, school-based, good collaboration with Minister of Education, good collaboration of local government. We don't have enough car. That's true. We borrowed the car of the police, and they were so happy to give us the car. When we don't have enough car with the police, we have the truck of the army. They were so happy to give to save our girls. So we found solution. This is the first shot in the country. I was with the First Lady, and this is what we have published, 96% 1 year. Because thanks to the community health worker, when the kids are not at school, there is in the village, they go and find them. So preventing is not enough. We fight for bringing treatment. Thanks to Larry, who is here, applaud him because he have done his best in Butare with you guy and you to help us to bring the capacity to treat cancer. We have already the great capacity to diagnose with the telemedicine and the Association of Anatomopathologists here. There is a lot of innovation we can do and bring a holistic cancer program. Of course, we continue to go together to find money and to make it happen. But we need to make it happen because this is social justice. And we have opened a cancer care treatment in Rwanda with, you recognize those people. There is a man there called Larry, I don't know if you know him, and Paul Farmer, and I don't have to present the others. And this is the center, and it's working well. Larry is going to publish a paper soon showing that our outcome, we may be poor, we may be with a lot of illiterated, we may have no lab, they are better than your outcome. We have that for HPV, we have that for HIV, we have that now for cancer. Another way to think about the science of implementation that everybody denies, but it's the true next frontier. People want to transform science in product. They forgot that they need to transform the product in health. And that's where we all come. With collaboration, we collaborate to change the world. With Larry, we have fought to include 16 new drugs in the list of essential drugs, because when WHO doesn't say that it's necessary for us, we cannot use philanthropic money to buy it. Can you imagine? So now we have increased the list. And we have also innovated in education with HRH program. It's a collaboration with 23 high institutions of education in the US who bring us faculty members for a year to help our university to transform their teacher in better teacher. It has paid fruit. Now, from 100 students a year, our university can recruit 300. And the quality have improved, the number have improved. But also, when I was in the ministry and before, I have put all my people on master program to give them the sense of rigor and the sense of evidence-based decision. And it has helped the health sector to work well. This is the HRH. It gives you a sense of the workforce produced in Rwanda, and also that the collaboration was high in the beginning, and as the Rwandan teacher take over, it's decreased. But the collaboration will continue because we can do together high-tech research. that we were not able to do before because we didn't have the people. We have built leaders that are the true leaders in implementation by giving them the possibility to understand better what research, evidence-based and rigor is, and methodology. And now we go for this new university that is my next fight. An university that wants to put equity in the heart of every education, that want to give to people like you and to all the people we will educate the notion that a doctor is okay, a nurse is okay, together they are better. But it's not enough. They need the veterinarian and the agriculture for a comprehensive program to make the population healthy. The comprehensive approach that we are doing together. So they will receive education together and just go for the specific that each field needs. We are going to graduate our first master cohort in global health delivery next month, start the medical school end of 2018, and the nursing school end of 2019. And we continue with dentistry, and we will invade the world with your collaboration, with a new spirit that the poor and the vulnerable have to be in front of the benefit so that everybody can benefit. I always say, if the grandchild of the poorest woman in Rwanda is okay, my grandchild is okay. And we have almost the same mission and vision, so collaboration are going to be very easy, guys. Delivery, equity, leaders, international, Africa, and in the world, change the world. You know, the Chicago School have done that for finance and screw the world with the crisis we got since 5 years. So we can do that for the world, to repair the world like my friend Paul Farmer is doing. Those are our partners, and I hope that Penn will be there soon. Cummings Foundation, bring that to your leadership. Because, guys, if we are not global, remove the word global from your institution. It's just health. You want to be global, be global. And we are there to help each other to be global. This is the campus. This is to show that we have people come already from Yale, Tufts, and many countries, and the med school soon. The lesson learned is that locally, we need to be on the drive seat. The experts are the community. We have the know-how, but they transform the know-how in success. Partnership is needed inside and outside. And we just have to accept to be learners, and to go for equity. But if we want to go to the next step, we need to give a hand to each other. So what I hope is that your philanthropy in this university that is yours will give 1% of its profit to global health so that your students can collaborate and be the global fighter that the world needs tomorrow. Thank you.
So she's not shy, as you all now know. So we're happy to take questions. I'm going to kick it off, by the way. And after the questions, we're going to have a reception just to the right as you go out, and you're all invited. So we'll take questions for what time?
Even from there up, we take questions.
We'll take questions for maybe 10 or 15 minutes, and then Dr. Agnes will be here for another half hour at the reception if you have it. But I'm going to start it off, Dr. Agnes, and ask you, when you formed the governance clusters, because a lot of this, frankly, right, depended on leaders in your country to be willing to get together and share. How many of the leaders that stepped up to the plate at that point were from the pre-existing, ministries and offices, and how much of it was dependent on bringing new people to the mission along with the pre-existing folks?
So it's a mixed. I think you are there because you are good. And you are there because you have ideas. And it's not because you are minister on the seat that you don't influence your country. The minister is just the first civil servant, so that means he's the first servant. And just there to take the clap when something is wrong. But the reconciliation process, when the first part of the presentation is we went for strong innovation in how we repair the country. Peace and reconciliation was not words. When I say that when I was in the National AIDS Control Commission and don't have enough money, we had doses for 3,000 people only. And we had to give, there was, let's say, 2% of the population in prison. 2% of that have to go to prisoners.
Please, if you have questions, come on up to the microphones.
Beyond clean cook stoves, what did you do to address energy poverty in Rwanda?
Energy?
Energy poverty in
Energy
Rwanda, beyond
poverty.
the clean cook stoves.
So we try to promote solar energy. We try to promote electricity, not through generator, but through, it's not really my field, but solar energy. We try to create, to not use wood, to use detritus. There is a way to do briquettes that burn in those cook stoves so that we protect the environment. Things like that.
Okay, thank you.
Did I answer your question? Sorry, it's not my field, so I don't know everything.
Conventional cook stoves, you still have the problem, the deforestation, and you have to develop a system for electricity to power your refrigerators. If you
So what we use also is biogas, meaning the people are doing, they have livestock, pigs, etc., and they use the biogas to light the houses and to cook. So there is a lot of initiative going in those areas.
Okay, thank you.
Okay.
So, Dr. Agnes, thank you so much for a very powerful example of how to build from bottoms up and to really use the community. Very inspiring stories, always listening to you. Now that you are building a School of Medicine and a School of Nursing, sometimes when we start thinking about building schools, we forget about the powerful approach that has happened actually in bringing health to the people. And we start thinking about building curricula coming from Western perspective. So in what way will building the curricula for nursing and medicine and health will benefit from this powerful story of starting at the community level and working with the community leaders?
Because in this university, community health worker will be faculty members.
Community health workers are going to be faculty members?
Yes. So academia shifts.
Okay.
Expertise.
Say more about that.
Say more. So that means the first year, our student is 6-year training. The first year, they will be educated mentor at community level by community health worker to learn about what is family health, what is community health. The second year, they go to the next layer under a nurse. All of them, nurses, doctor, dentists, at sector level. And after, only, they will be facing a traditional hospital. But those community, even in now we are building the university, there is a steering committee at community level to follow if we do the right thing. They were there in the building, the designing, and the nurses over there are there to say, this is what we need, this is etc. So we apply the same principle of participatory protest, and I'm not an expert in architecture, I'm not an expert in building, and the engineer have to transform their wish and good idea.
Nancy?
Thank you for all the inspiring example of your country, of what you've done. And Afaf's question actually is a leader to mine. I was very curious about your 45,000 community health workers. What's the starting place, how you recruit them, what kind of compensation, what's the scope of knowledge they have, and since they're going to become faculty, it's an even more important question.
Yeah, so how they are selected. they are elected. So each village is around 200 houses. They have to elect 2 women and 1 man. 1 woman only to follow pregnancy and children that will go under preschool. For the time being, before it was 1 year. But we are going to add early child development, so there will be more to follow. The 2 others are for common disease, malaria, TB. They give antibiotic. They have only 6 weeks of treatment, syndromic approach. You cough with fever, no other pain, you can do this. 24 hours, no improvement, you take the person, you bring the person to hospital. It has bring 2 things. First of all, if you are lazy or too tired, you can just say to your child, go and get the community health worker. He come at home, he do the test, he start the treatment. He have come to see you back the day after. No improvement, he tell you now, guys, it's time to go to the hospital. And you all know how we are when I'm sick. We say, oh, I'm sick today, I will see tomorrow. And the tomorrow you don't have time because the kid, etc. But when your community health workers, who have the legitimacy of the village, told you time to go to the hospital now, you don't say no. So you have access to treatment earlier. They have a refreshment every year, 1 week. And if the community doesn't want them anymore, the community vote another one, and the ministry is in charge to educate that new one. So that means it's community health owned by the people. They are volunteer, but they are compensated on performance, pay for service. Malaria is 200. Transfer malaria, we don't give incentive to keep the person and treat. Transfer a malaria on time is this much. And so we pay for good health. How we secure the money for the future? For the time being, a lot was paid through donors and through the government. What is paid through the government will stay. But what we pay by donors, we have created small business in each sector. A sector is 16 villages, roughly. A business, community business. And the benefit of this, 30% will be directly distributed in the pocket of the community health workers to thank them for who they are. And 20% have to be reinvested in the business. This is the law. 50% will be pooled for this refreshment training or new training, for new boots, new lamp, new medicine, and also for this pay for performance. We still have a long way to go because we had only 600 billion Rwandan franc profit last year. We need to go up to 4 billion, but we have 478 little business that will grow year after year.
Fantastic, thank you.
So we have generate wealth through health issue that generate health and wealth. And
So we have time for one more question, and then we'll break for the reception.
Hi. Thank you so much for this talk. It was very interesting, and I guess I kind of have almost 2 questions. I'd love to hear more of sort of your personal anecdotes and experiences. You've clearly achieved so much during your term as Minister of Health, and I'd love to hear, what do you personally feel most proud of amongst those achievements over the 5 years? And then if you're able to speak a little bit more from your perspective on your transition from that role.
so the transition is very easy. I'm doing now what I was doing during my free time, weekend, night, and holidays for free, and I'm paid for it. So transition has no problem at all. I was teaching in Harvard since 2007 to Dasmus too, and do some run like that on my holidays. And now, so no problem. What I'm proud of, I just come from Oxford, where somebody said, never trust somebody that is not angry. So I don't know what I'm proud of. I will be proud when we continue to flourish. I'm not yet.
Great. Never be satisfied. So thank you, Dr. Agnes. All right.